A very good evening to all of you, my respected seniors and colleagues from all over India and the world, which I am proud to say. Today, Chest Council of India has brought to you in a part of its lung cancer webinar series, another webinar which is of utmost relevance. And I would say that as practicing pulmonologists, it is very important that all of us be well equipped and well acquainted with what is going on with end of life care, palliative care, and giving comfort to the patient at that point of time where we actually know that none of our knowledge or skills will or might be able to help this patient. Not only the patient, but even the family is in a situation where we need to act as that particular saving and comforting soul that is very much mandatory. Now, palliative care in itself is a specialty, and we are very much astonished by the fact that what all palliative care can do. We have a very I would say accomplished specialist of palliative care medicine in the form of Dr. Manisha, who is attached to the Cancer Research Institute at Ranchi, which is a Tata Hospital exclusive oncology center. I would like to welcome Dr. Manisha to today's CCI webinar on this particular palliative care medicine. And I have no shyness in saying, ki, Madam, this is your webinar today. We are just here to discuss and learn from you, ma'am. So welcome. Followed by that, I would like to, it is a great privilege for me to introduce someone whom I used to really idolize in my days in Hyderabad. Sir is one of the most hard-working pulmonologists that I know. And the best part is it has been more than 20 years that I have left Hyderabad, but it feels so warm. And sir always gives remembrance to his old student. I would like to welcome respected Professor Dr. Pradyut Waghray, sir, to today's CCI webinar, sir. Lots of welcome, sir. Sir is a person who truly needs no introduction, but as my duty, I would like to introduce sir as the MD of KIMS Hospital Private Limited, and sir is also the head of the department at SVS Medical College, apart from being one of the legendary senior consultants at Apollo Hospital. It is my true privilege, sir, and you're our most experienced batsman today, Dr. Manisha and Dr. Pradyut and Dr. Manjunath, whom I'll be introducing, are the three in which almost in all the case scenarios that we'll be discussing, I'll be taking your kind expertise on. Apart from that, the young team, well, I would like to, start with the youngest, which is Manjunath Bale Sab. He is the surgeon amongst all of us. Dr. Sab is at Yashoda Hospital, and a lot of people are telling that he is so deeply awaited that they might even rename Yashoda Hospital as Manjunath Hospital, sir. So we are all looking forward to discussing with you, sir, because as a surgeon, your role in palliative care medicine, I know, seems a bit strange, but is very, very important as far as pulmonology is concerned and is very relevant. Sir is currently logged in from China. So I would really thank sir for giving this webinar the international taste and flavor that it truly deserves. Our Young Turk Brigade is from north to south to east. So beginning from north, we have Dr. Utkarsh Gupta with us, who is at Noida. He is at Heritage Hospital, Noida, where he heads the Department of Pulmonology. So I welcome Dr. Utkarsh to today's CCI webinar. Looking forward to discuss with you. Going east, where the sun rises first, is Dr. Soumyadeep Ghosh, who is an assistant professor at Shantiniketan Medical College, Burdwan. It has been a true, I would say, the youth and assistant professorship has a lot of vigor and enthusiasm attached to it, which I could palpate when we had the Saubhagya, I would say, of including Soumyadeep to this webinar. So welcome, Soumyadeep. I believe this is your first CCI webinar, and I wish you all success in many more webinars to come. Looking forward to discuss with you. And my dear friend, who corrected my Malayali. I started calling him Anna, then he told that he's not Anna, he's Anaya. So my dear Phillips from Calicut, who is from he's from King's Hospital, Kannur. He is currently in the Department of Pulmonary Medicine over there as a consultant pulmonologist. So I would like to welcome dear Phillips to you. Now today we have devised our webinar in a different way. Before I get too carried away in today's stuff, it's my duty, I feel, to thank the organizing team behind this webinar, the technical team, the pharma support from MEGHMANI, and last but not least, our respected Dr. Krishna sir and Dr. Narayan Pradeep, Dr. Ashish Dubey sir, Dr. Anil Maske sir, and all like Dr. Atri, Dr. Shivani, Dr. Kirat, who are the think tank, and of course our Dr. CVK sir, who is the biggest force behind all of us when we do these webinars. So without taking up too much time, I would like to tell today's flow. We will be having a very interesting presentation by Dr. Manisha, who will be busting a lot of myths that we have about palliative care, followed by which we have a absolutely case scenario based discussion today. So it might be a little different from what you expect in little in CCI webinars, but we have tried to keep it very relevant because as pulmonologists, I think वो अपने भेजे में ज़्यादा easily चले जाता है जब case based हो जाता है. So I would like to now call upon Dr. Manisha for coming and busting a lot of myths. Welcome, Dr. Manisha, to the grand platform of CCI.
Good evening, everyone. I am Dr. Manisha, and I am consultant in palliative medicine at Ranchi Cancer Hospital and Research Center. First of all, I would like to thank the CCI committee for giving me this opportunity to talk on busting myths on palliative care in lung cancer. All of us know there is a huge symptom burden in lung cancer, which affects the quality of life of patients as well as their caregivers. And if you look at the incidence, that is the new cases, it has been around 81,000, which constitutes around 5.8%. And most of the times, palliative care is misunderstood. So, the objective of my presentation will be how I can bust the myths and highlight the facts. So this one is the Globocan data of 2022, in which we can see here that the lung cancer constitutes around 81,748 new cases, which constitutes around 5.8%. So we can see here it is the fourth most common cancer in terms of incidence. Now coming to the origin of palliative. So we always think that palliative means something which is end of life. But actually, the real word pallium, it came from the outer garment or the cloak, which means this something which will lessen the severity of the symptoms of an illness without curing or removing the underlying cause. However, this definition may be somewhat some misleading that it is without curing or removing. Though this definition, this term has been used since the time immemorial, exact date I can't say, but the word palliate means how we can lessen the severity. Now, coming to the WHO definition of palliative care, it has this WHO definition of palliative care. It's an approach which says that improves the quality of life of patients and their families who are facing the problem which is associated with life-threatening illness. So it doesn't just mean that it is just cancer. It also has it also encompasses the non-cancerous cases as well. How it will do? It will do by the prevention and relief of suffering by means of early identification and impassable assessment and treatment of pain and other problems. So the problems are not just physical, it is also psychosocial and spiritual. It also coming to just more elaborating what is palliative care. It is the relief of pain and other distressing symptoms, and also it affirms life and regards that dying is a normal process. And most of the time we think that dying is abnormal. But if the disease progresses and end of life approaches, dying is a normal process. It also intends neither to hasten or postpone death, and it also integrates the psychological and spiritual aspects of patient care and offers a support system to help patients live as actively as possible until death, because the patient live until they die. Now you can see here the one picture which is over here. So what we usually think that palliative care is just terminal care or end of life care. However, you can see here through this picture that end of life care and terminal care is just a part of palliative care. However, this palliative care is a broad spectrum which also includes the how we can maximize the quality of life. It also includes the surgery. And we all often think that how can the surgery and the palliative care can be together, right? But if you look at, suppose if there is any obstruction, if I'm talking of lung cancer, if there any central airway obstruction, so either we are doing the stenting or if possible, if we are removing that tumor, we are just mitigating the suffering of the patient. So if we are decreasing the suffering of a patient, it means we are giving palliative care. And now coming to the end of life care, which means that the lifespan is in weeks to months to live. However, the care or the terminal illness means there are just a few days of our hours of life left with the patient. In that case, also in terminal care, also we can provide the spiritual care, the symptom management, and the psychosocial support of the family so that the wishes of the patient can be taken care of. And it also offers a support system to help the family cope during the patient's illness and in their own bereavement, because not the family members also suffer a lot after losing their loved one. So a lot of times it may be a simple grief, but for some patients it may be a complicated grief. And also it uses the team approach to address the needs of patients and their families, including bereavement counseling if indicated, because we all know there are complex needs of any patients who is approaching end of life. So multidisciplinary team is the need of hour for enhancing the quality of life, not just the patients but as well as their caregiver. And also if it is applicable early in the course of illness with the cancer directed treatment, like the patient will be on chemotherapy, radiation therapy, or if some plan for some surgery or anything, it will decrease the distress of the patients and also the complications. Now, what is the trajectory of illness? So, initially the first graph which you are seeing is what we used to think earlier of palliative care. Either you are giving the curative treatment, it means that you are just prolonging the life by giving radiotherapy, chemotherapy, or any cancer directed treatment. And if you are just stopping the cancer directed treatment, the suddenly the patient lands to either hospice care or palliative care. However, it has taken some time to go from this life prolonging care to this life prolonging care plus palliative care, which you can see here, which goes side by side. Of course, as the disease progresses, you can see here the role of palliative care becomes more significant. But there is a twist in lung cancer, right? We all know that with the like a lot of times now, immunotherapies and newer modality of treatment has come, especially in lung cancer. Now it's not a straight line like I which I just saw, which I just marked it here. It is now you can see here some wavy pattern. It means, suppose if you are giving some next line of treatment, patient is not responding. So, like if we are giving here a different type of immunotherapy, because here you can see here there is more of palliative care and less of curative intent. So suddenly, what will happen? The patient's quality of life will improve, patient will be on the life prolonging treatment, and then again the patients, you can see here this graph, so the patient will more need the curative treatment and less of the palliative care. However, we all know that this graph, which means the time graph, will go on, and ultimately the patient will be exclusively on palliative care and at last death. But we don't We don't stop here itself, but we provide even bereavement care to the caregivers who are suffering of the loss of their loved one. Now, I think that all of us will be aware of this RCT. I would say that it was just a milestone in the field of palliative care. In this, what they did was, they have taken 150 newly diagnosed metastatic non-small cell lung carcinoma, and they have randomized into 1:1. In one group, in which there were 77 patients, they gave early palliative care. Early palliative care, it means that within the diagnosis, within the 3 weeks, the patients were referred to a palliative care team. And in the second group, there was a standard oncology care, whatever the cancer directed treatment the patient was getting. And in that case, the palliative care referral was given only when the patient told that, no, I am having some symptoms and I need some specialized care. So they were randomized into these two groups, and the primary endpoint was the quality of life, and the secondary endpoint was the overall survival, mood, and what is the use of healthcare services, aggressiveness in the end of life. And and the results were really promising. That the results showed that it improved the quality of life in the intervention group. It means those who were referred within the 3 weeks of diagnosis, and they were also lower depression scores. And however, in that other group, in for the other group which didn't receive the early palliative care referral, they had more aggressive end of life, and also there were less advanced care planning documentation. And through this graph, you can also see that integration of early palliative care, it didn't decrease the lifespan of the patients who were receiving the early palliative care. Now, we always think like, what is the quality of life, right? But again, WHO has come with, I think WHO is a savior, right? So he has come with this definition, like it's an individual's perception may differ from one person to another of their position in life within their culture and value system related to their goals, expectation, standards, and concerns. And we all know that the culture and value system differs from religion to another religion. From India, maybe it may be different in India, maybe different in US or the Western countries. So it is just a subjective concept influenced by the physical health, the psychological state of the patient, personal belief, and what is the social relationship, and what is the environment. And now we often talk of what is the quality of life. The less talked thing is the quality of dying and death. And we often don't talk of about why to talk of death, right? But the quality of dying and death has its importance as well. And it is also emphasized on the person-centered care, which includes the patient's and the family wishes and the absence of the avoidable sufferings. If we will see in the case of CA lung, right, if it will be, see if a patient gets extensive metastatic lung carcinoma and multiple lines of maybe chemotherapy, immunotherapy, and we are exhausted with everything, right? And suddenly the patient comes in terminal breathlessness. All of us will know that the ventilation or intubation in this patient is not going to help, right? So at least we can provide preferences. We can give this menu. I would say that we can give menu to the patient. Of course, the final choice will be of patient, right? Okay, see, even if you are going for ventilation, definitely you are not going to increase the lifespan, and and on the other way, you are going to increase the suffering of the patient. But definitely it should align with the patient's and the family's preferences, and it should minimize the physical, psychological, social, and spiritual suffering, and is consistent with the culture and the ethical standard. And like the culture, what I have seen is like if a patient is dying, right? A lot of times, if you will see of Hindu mythology, sometimes the patient's caregiver will tell, "Nahi, I want to have some that Ganga jal, right? Ganga jal or some tulsi in my mouth." Or if Muslim, the a lot of patients, those who are Muslims, they will say, "No, I want to hear some azan," or they want to keep their head on the side of Makkah. So all these things, we should ask patient. Then only they will think that okay, this is relevant, and at least even if we are dying at hospital, this can be done even in hospital setting. Now, you know why I have talked so much of quality of death and dying? Because this the study which was published in 2021, and what they have taken in 81 countries they have taken just to study what is the quality of death and dying. And unfortunately, our India came in on 59 position. It means like at the time of dying, patient have a very poor quality of death and dying. And I can't give you a better example than this Aruna Ramchandra Shanbag case. So this was one young female, and she was in vegetative state for more than 42 years. And her caregivers actually requested for passive euthanasia because there was no point in increasing the suffering of this patient in 2021. But it was rejected by the Supreme Court of India. Unfortunately, she died 4 years later in 2015 with pneumonia. Now the choice is ours, and also not just mine, yours. It should be the patient's choice. Like whether they want to have all these interventions, the one which you are giving, which you are seeing over here, or you want to have your last days of life with your loved one, whom you want to be with. Now, a lot of myths are there, especially when we talk of palliative care. So, let us debunk myths, and we will just fill this gap with what is the fact. So, just hold on, there will be a list of myths and there will be a list of facts. And this one is the myth one is it is only for cancer patients. But as I told you earlier, as per the WHO definition, it is for all life threatening illness, including the heart disease, kidney failure, dementia, and many more. The list is countless. And the myth two is the end of life care, and it is only for dying patients, right? It is myth two is palliative care means it is end of life, and you should offer to those patients only who are dying. But as I told you earlier, it starts with the diagnosis, and even after the death of the patient, it we have extended our support to their loved ones. Myth three is like it means it is giving up on care and treatment. It means that we are saying tata bye bye to patients now. We are not going to offer anything. But it is on the other way, right? It will just complement the treatment, and it will improve the quality of life, and it will alleviate the suffering. Because we all know that as the disease progresses, there will be more increasing burden of suffering. So the best we can do is at least the alleviate the suffering of the patients. And we always think that it is just about pain and the physical symptom. But most of the times we are missing is addressing the emotional, social, and the spiritual needs of the patient, right? Like most of the times patients will be in spiritual distress. Spiritual distress means like they will be asking questions, why I got this disease, why me? And they will be just searching these questions within themselves. And most of the times what happens that patients themselves, they will not ask from their caregivers. They will think that why to ask from my caregivers who are already burdened by taking care of the patient. So somewhere all this spiritual distress, emotional distress, that kills the patient from inside. And that is the unseen suffering, which at least we by asking us, we can't ask, we cannot see, we will have to ask patient. And coming to the another myth, like take if we are talking of palliative care, it means like we are taking out all the hopes, but actually it will identify the realistic goals, and it will maintain the dignity, and it will actually allow, it will give the menu to the patient, like, okay, now your disease is progressing or it is static. Now what are your choices? How you want, how you want to be your some the last days of life, or whether you want to have any IV cannula, or you want to have Ryle's tube or anything, so that we are maintaining the dignity of the patients, and we are also involving uh, in the planning of him or his care. Another myth is it means like we are just giving up everything, all the treatment, but it will improve the quality of life of patients. Another is like if we are just sending patient for palliative care, it is going to hasten that death. As I told you, the study which I mentioned earlier, it has not yet shortened the death. In fact, it has improved the quality, the comfort care, and the dignity of patient. And we always think that palliative care means it is only for patients, but we have extended the support to the caregivers as well, because they also suffer from the caregiver burden. So there should be someone who can actually listen to them, and who can give them the solutions, like how they are suffering from this caregiver burden and what can we offer to them, so that they should not feel overburdened by taking care of their patients. Now, we always think that euthanasia is a part of palliative care. The word euthanasia is a intent. Euthanasia means you are just killing the patient. So it is not actually it doesn't support the euthanasia, because euthanasia means something you are giving to patient so that you are hastening the death. But palliative care, it doesn't promote hastening of death. It doesn't support it. In fact, it promotes the comfort, dignity, and the holistic care. Another myth is that palliative care and hospice care is same. However, it is not like that. In the circle which I showed earlier, I think in third or fourth slide, in which I have mentioned that palliative care is a bigger picture. However, the hospice care is just a smaller, a part of palliative care. And a lot of myths about morphine. Like if we are giving morphine, this will lead to addiction. But in fact, if it is given under supervision, we will have the better pain control, and it will not lead to addiction. And one more thing is there, morphine means like now you can count your days in life, like you should be given only in the last days of life. However, if you know that if their pain will be controlled, they will sleep better, they will have a better quality of life, their pain will be controlled, and they will be more hopeful. Now, the 13th is it is expensive, but actually, palliative care is cost effective by reducing the healthcare expenses and unnecessary hospitalization. And also, we always think that palliative care is just for adults, and it is nothing to do with children. But it also supports neonates, infants, and children to ensure their emotional and physical well being. And I know many of you would have bored like, what is this 14 list myths? And I know the list is countless and it will keep on continuing. So I will just stop here, and my just last slide is this is the comic picture which was published in March 17 JAMA. And here you can see the upper picture where you can see that initially that patient was not provided the palliative care. The patient didn't take the palliative care. But a few months later, what happened? The patient deteriorated, and after that, the doctor gave him this umbrella. And now the patient is thinking, thanks God, if it would have been better if I would have got it earlier. Right. So, and in the second picture, if you are seeing that just in case, like they are just, it is going, the palliative care is going along with the curative care. So, when the patient needed it, when the patient needed that support, at that time, they just opened that umbrella. They they are actually protected from the rain. So, the we always think that palliative care is the rain, but actually palliative care is the umbrella which will improve the quality of life of the not just patients but their caregivers as well. You can see here in the umbrella the patient as well as the caregiver is there. So now just thank you, and I will just end with this slide, which is by Dam Cecily Saunders, because you matter because you are you and you matter at the end of your life, because just we will just help you to die peacefully, but also uh, to live until you die, because any patient they are living until and unless till their last breath. Thank you. And I would love to have questions. So if you have any doubt, you just ask me. And if any myth which is there in your mind or anything which you think that you had doubt or anything, you just ask. And I'm happy to take all the questions.
Wow, a very, very thought-provoking presentation, Dr. Manisha. Thank you for this very, very nice overview of what palliative care medicine is. You know, all of us have grown up seeing this very famous movie called as Anand by Rishikesh Mukherjee. And there is one dialogue in this in which it is told that मानता हूं कि जिंदगी की ताकत मौत से ज्यादा बड़ी है, लेकिन ये जिंदगी क्या मौत से बदतर नहीं है. So this dialogue was told by the particular character in this film when he was diagnosed and describing his pain to his friend. So I think what the essence of palliative care medicine I could get from ma'am's presentation was that we need to care. We need to strive as pulmonologists and doctors to make the quality of life of that particular patient and his family worth living. So इन हाँ इस जोश में इस प्रेजेंटेशन के आई फॉरगॉट टू इंट्रोड्यूस माई सेल्फ. आई एम डॉक्टर रवि डोसी एंड आई कम फ्रॉम इंदौर मध्य प्रदेश. I am CCI Central Zone Governor. So now I would go ahead with this very, very interesting webinar on end of life care. But before that, I want, Dr. Manisha, since I have heard about this particular degree that you're MD Palliative Medicine, one thing, two questions come in my mind automatically, Dr. Manisha. Please unmute yourself. One is that, Dr. Manisha, why did you become a palliative care specialist? And secondly, what exactly is palliative care medicine? मतलब हमारे तो ओपीडी रहती है, आईपीडी रहती है, आईसीयू रहता है और वो पूरा कचपच रहता है. How do you do things?
So, initially, when I took this degree, I didn't know anything about this course. I was getting some 2, 3 branches in like radiotherapy in, I think, AIMS, Bhopal or Rishikesh, something like that. So, I had 2, 3 options. I just searched on net and I saw that palliative care is given so much importance in the Western countries and all. So I took this branch. But I went to my department. I liked that branch so much. So taking palliative medicine was just like by chance, but continuing is my choice.
Great, ma'am. So, but tell me, ma'am, you presented very beautifully. Ma'am, pan India, pan world. I apologize. I am not Hindi. I am not English. I am English. So bear with me, please. So, ma'am, बताइए, what exactly is palliative care? मतलब for a basic pulmonologist, why should I call you to see my patient? Please tell me that.
So, as a I will just take this whole picture. Like a lot of patients who are just pulmonary, I'm not just talking of cancer. A lot of patients like COPD and all who are of end stage of COPD and all, they will have a lot of symptom burden. Like the symptom burden is not just physical, as I told in my slide. It is also the psychological stress, the spiritual stress, and all these things. And I know you people are so much busy. Everyone is looking at the physical stress, but no one is looking after that the other stress which the patient is going through. So, like if you're taking the holistic approach, that can be done only by the palliative medicine physician. And also, when the end of any pulmonary, any disease like COPD and all approaches, they have the terminal breathlessness and all. So at that time also, like we can provide comfort to those patients, like with dyspnea and all. They will have terminal dyspnea. They will on home based oxygen therapy and all. At that time also, like we can give narcotics. And I know you're doing a lot of things, but other aspect of care that can be managed by a palliative care physician.
I do agree with you. And in a busy or in an average day, we actually,
Yeah.
we are don't manage to give that comfort to the patient that he actually deserves. So I really respect your specialty, and I would like to even call in now one of our panelists, Dr. Utkarsh. Dr. Utkarsh, how are you?
I'm good, sir. How are you?
Yeah, I am fine, thank you. Dr. Utkarsh, I think all of us appreciated the webinar, that presentation which Dr. Manisha gave. It was eye-opening on a few myths that she busted for me. But tell me, you are a pulmonologist, मेरे भाई हो, बताओ मुझे, what are the domains and concepts in palliative care? What do you feel they are?
Sir, coming on to the domains, I think the first part that is very important is a construction of a multidisciplinary team. So we should start with a multidisciplinary team and decide on the approach and the treatment care plan for this patient who is up there for the palliative care. And after the formulation of this care plan, the first part that comes is the relieving of symptoms. So I'll say that the physical aspect of the care, and then improving the quality of life, functional ability, then taking care of psychological support, social support, coming on to the cultural beliefs and the religious aspect of it. Then comes the end of life care also that we have to talk about with the patients, and following the ethical aspect, keeping in the mind that what all is ethical in our practice. So this is what I'll say are few of the crucial domains of the palliative care. And how we practice this. So the very important part of I'll say in every field of the medicine is the communication. So the day we became doctors, so the first thing that was taught is an effective communication with the patient, with the family of the patient is very important while talking about the palliative care and even any of the symptom or management. And then comes all this, the physics that I talked about, like managing of symptoms, improving the functional status. We have to explore what is the understanding of the patient, what is the requirement, what they are thinking about, and be very clear about the prognosis so that there are some kind of unmet needs of the patient that we can cater to. So I think these are the crucial domains and the concepts of the palliative care.
Very well spoken, Utkarsh. For a beginner, you are very clear in how to palliate your end of life care patients. So I do understand. But now I want the masala of little experience. Respected Pradyut Waghray, sir, I have seen you counsel your patients and their families, sir. So there is no other better person that I feel who can explain to all of us pulmonologists, sir, what is the role of the pulmonologist in palliative care, sir? हम क्या करें हमारे उन patients के लिए?
I think pulmonologists, we have a very crucial role in this multidisciplinary team, because once the patient with suspected, assuming it's a case of lung cancer, since we are discussing that, if that patient comes to you, your first job is point of contact is you. You do the bronchoscopy, you do the diagnosis, you get a diagnosis of carcinoma. So you are the point of contact, number one. Number two, you also take part of the complications which are associated with the carcinoma or any other lung disease what you are treating, both as with concern to the disease and with the result to the treatment as well. As Dr. Manisha has beautifully presented, it is very important that the palliative care begins right at the time when the diagnosis is made, because it is always important to discuss with the patient. See, this is your result. You are having a carcinoma. Treatment is there. Treatment is going to continue by the oncologist. The symptoms I will be taking care part, and other issues like your psychosocial support, your emotional support, to some extent even the family support and the caregivers support will be taken care of by the palliative medicine specialists, social workers, and other people, and psychologists, etc. And as madam has very rightly said, this spiritual one is very, very important. Most people, when they are dying, I have seen, they asked us to put some Ganga Jal or some other thing as per their religious preferences. And that is very important and gives them a lot of soothing. See, we are not treating as a disease. Disease is not an entity to be treated. Death is, there is a dignity in death. A person, that lung cancer person will die, if not now, after 3 months or 6 months with all your chemotherapy and radiotherapy. But all through the journey, from the diagnosis till the death, he needs to be leading a very, very dignified and a comfortable life. His symptoms should be controlled, where we come into picture, dignity of life, everything, where palliative medicine come into picture. So I think that's how a coordination between pulmonologists and other teams of the palliative team plays very important role.
Right, sir. Right. Thank you, sir. Really, I agree with you, sir. And at times, when we are busy, we should learn from what sir has just told us, and we should give a lot of importance to this particular aspect. Sir ने एक बात बोली, diagnosis, which even Dr. Manisha told. So tell me one thing. Taking a cue from what Dr. Waghray sir has told as the role of pulmonologist, but Dr. Manisha ma'am, you are an expert. Tell us how to deliver a bad news to a family or a patient. Is there any proper way that we can do it?
First of all, we should define that what is the bad news, right? So bad news is something like if you will tell it to patient or their caregivers, their whole future, they will have some negative emotions, and their whole course of action, what will be there after the diagnosis, that will change, right? And I would say that there is no single recipe for it. This may sometimes one thing will work for one patient and another thing will not work for one patient. So there is one protocol which we usually follow, but definitely many a times it is different for other patients. But that's one usual is that spikes protocol. So before delivering anything, there should be a setting. It should be a quiet environment. If your OPD consultation room is okay, but yeah, it is very difficult in some government colleges and all to find a setting, right? Second thing, what we should ask is the perception, like what the patient already knows about it, and whether it is a metastatic disease, and what he has been told by the primary care giver, the primary physician. And then we should invite him ki, okay, this all these things are there. Do you want to know whole thing, or I should give you in bits and pieces? Sometimes what happens, like the one who is coming to you is not actually the decision maker. Sometimes they will tell you, nahi, there is some other person who is the decision maker, and they will call them. So we should invite them. Then second is the knowledge, SPIK. Now there comes the K. K means like the knowledge which we are giving him, what is the stage of disease, and also you are setting the goals of care, because goals of care also changes from, like, if the disease of stage 4, your goals of care will be exclusively curative. But if it will be stage 4, your goals of care will be of palliative intent. So goals of care needs to be told to the patient. Now comes the E. E means empathy. So you should be ready with the empathy and emotions. So you should be ready with the emotions. Sometimes it happens like the patient will start crying, right? So what I usually do, if sometimes patients will start crying and all, I will tell, okay, I understand that what you are going through is normal. All the patient, and usually what I will give you one example. Okay, the same patient was like that, and he was also having the same disease, and he also had the same sort of emotion, same sort of symptoms and all. So by this, what will happen, like they will be able to correlate with that patient and their caregiver. And after that, when you are doing everything and all, then you should summarize ki, okay, your disease is stage 1. Now this thing, you will have to go to a surgical oncologist, or you have to, if a single lesion is there in your leg, they may go for pneumectomy. Or if it is advanced disease, you should go to a medical oncologist. And apart from that, if you have symptom burden, we are there always for you. So this will give them a clarity that this will give them a pathway and clarity that actually what we are telling him, that we are giving that okay, you will have your surgery, so the treatment plan is there. So we are not just losing the hope, we are also giving them a pathway on which they should go along with the patient. So this is usually I follow. And please just remember, sometimes it will happen the same questions will be again be asked from you in your next visit, and they will tell you and they will ask you the same question. So it from spikes again, they will have the same set of emotions. So repeated counseling is very much important in every visit.
Right, ma'am.
So
So, but this actually is a big skill that you are telling. Breaking bad news, or let's say important news to somebody. You have actually told about the spikes protocol, which includes such a lot of aspects. And if we go by that particular protocol, it will really be much simpler to deal with such situations. But nowadays, ma'am, I have also heard of a term called as advanced care planning, or a living will sort of thing. So what is
yeah,
this, ma'am? What is this concept that is we are hearing about?
yeah. So advanced care planning, and I won't say advanced directive actually, and living will. These two things are same. And I'll just talk of advanced care planning first. That advanced care planning, you are just making a all those care plan, medical care plan you are planning, that if just in case, if you are reaching to a situation, or in your latter part of life, if you are having some terminal illness, or if you are not making you are not able to make the decisions what medical treatment you should get, so you are making one will, that okay, so there is a lot set of questions are there, like you whether you want to have IV cannula or not, or in case if your general your if the performance status decreases, you're not able to take the decision, then what care should be given to you, like you whether you want to have any rice tube or not, for feeding what do you want, or whether you want TPN, or if whether you want to get intubated or not, you want to have CPR or not. So everything is there, and you will also nominate a person. Like in case, okay, I have done all these things, but in case if you will have to if doctors or anyone will have to ask like who will be the decision maker. So you are also appointing a surrogate decision maker who will take decisions in your absence. And this is and living will is just like a normal form of advanced directives. So it is just normal person use the word living will, and the other just like a medical term is advanced directives. So in advance itself, you are just declaring what are your wishes for your future medical plan.
Right, ma'am. So, it is like sort of when we counsel a patient's family for a DNR, there is a detailed 20-point division as to what they want, what they not want. The difference here is that the patient himself is able to give this prior to something bad happening.
DNR is different. Like
Ah,
DNR is do not resuscitate. But if
right,
you look
right.
at the ICMR, there is DNAR, do not attempt
DNA.
resuscitation. Yeah, it is
Okay.
DNAR, do not attempt resuscitation. And in that case, there are a lot of like questions are there. First, there will be name of patient and everything, the what the disease the patient is suffering from, and the primary physician they should write that why they want to suggest them DNA, do not attempt resuscitation, whether it is a terminal illness or whether it is a progressive disease. So everything should be mentioned. And if a patient is able to take the decision, then you should get it signed from them, or otherwise, who will be the surrogate decision maker, that they can put the signature regarding that, whether they want to for CPR or not.
Right. Dr. Manjunath, I just want to ask you one question. Are you with us, sir? Dr. Manjunath, sir?
Yes, sir. Yes, sir.
Yeah. Tell me one thing, sir. As a surgeon, you are an excellent surgeon, sir, referred very complicated cases. Breaking this important news or breaking bad news, sir, how do you go about it? How do you counsel your patients and their families, sir?
Sir, I feel in terms of Breaking Bad, I think honesty about the disease is a very important aspect, especially to the family. And sometimes you can start off with telling the family and then take the patient into confidence and tell them. I always try to do that because that way you have one person to support you from their own family. For example, if there is a son, I talk to the son, try and tell him that, okay, your father is so and so, so and so, so and so. And then we try to tell the father the next day, because suddenly if you tell the father and if there's no one around, it's a very traumatic experience for them. So I think this way it brings about a little bit of confidence. You also tell them some positives, because you cannot just tell everything, okay, that this is the end of life. We can give them options now with targeted therapy and so many molecules. Survival has been getting better and better. So even if it's a stage 4 malignancy, we still tell them that there is hope. I give an example of Sanjay Dutt, for example. He's had stage 4 malignancy from 2020, 2020 or 21, and he's doing movies every day. So if you have a good gene mutation, you may still have chances that you can still prolong your life, even though if you're on stage 4. I tell such examples and then try to make them feel better. Although we discussed about the protocol, I think that was a very good that's a good protocol where you involve you create a scenario, you try to have empathy, you try to tell them, you give them knowledge about everything, and then you ask them to take it from there.
Right. Waghray sir, please sir.
Yeah, I'd like to add one point that again brings us to the question of the role of pulmonologists in this whole team. Because see, the patient has confidence in you because you are the first person who saw the patient. And if the pulmonologist, as a pulmonologist, that becomes our responsibility to take the lead and talk to the other specialists, where you can do a counseling and then take the patients into family into confidence as well and tell them this is what we have done so far. Now this is the one which the bad news you have to break, and this is what it has come. These are its options. So these are the limitations. So that's where we play a very important role in actually counseling this patient, because we are treating them since a long time. I have a patient with me who is 85 years now. He has been operated for right upper lobe cancer. That time they was to go to Tata Cancer in Bombay. This is his 19th year of operation. They have given him an award there, some presented him, and he is so confident. He brings a Cadbury every time. He knows he has cancer, but his family support, doctor support, social support is so fantastic. He's still a practicing lawyer. So I think the palliative care is very, very important because we are not only curing the disease, we are treating the entire human being as such.
Right. So very, very relevant points. And there was a dialogue by again Rajesh Khanna in the film Safar that कैंसर के कीड़ों के सामने न मेरे जिंदगी की कोई कीमत है न तुम्हारे आंसुओं की कोई कीमत. बट आई फील अब टाइम आ गया है कि उन चीजों को कीमत देनी पड़ेगी. वी विल हैव टू गिव इंपॉर्टेंस टू दीज एस्पेक्ट्स बिकॉज नाउ लाइफ एंड द प्रेशियसनेस ऑफ लाइफ इज सो मच. So now I would like to move ahead and I would like to start with a few case scenarios, and I will be sharing my presentation. Dr. Utkarsh.
Sir.
Yeah, Dr. Utkarsh, I believe you have shared a very. Is my scene visible to all of you?
Yes, it's visible.
Yeah. So we have a few case scenarios, common day-to-day case scenarios which we as a pulmonologist might face. So Dr. Utkarsh, I'd like you to present your case scenario to us.
So this is one of my patients who came to me like around a year back. So he's a 58-year-old male who was a chronic smoker with a 35-year of back history. He was diagnosed with a squamous cell CA of left main bronchus. And after certain treatment, so at his ECOG score was 2 to 3. So he came with progressive breathlessness of grade 4 with recurrent cough and blood streaking sputum, multiple admissions with post-obstructive pneumonitis, stridor and wheezing episodes despite interventions that were done multiple times in the past. Whiteley saturation was 93% with slightly raised respiratory rate 26 per minute. We can see the X-ray, CT and the bronchoscopic findings. So initially CT scan was suggestive of left hilar mass with near complete occlusion of the main bronchus with the bronchoscopy, which confirmed after biopsy the squamous cell carcinoma. Patient was received concurrent chemo with cisplatin and radiotherapy. Patient was better after chemo and after certain interventions which were done for 5 to 6 months. a stent was placed, and then he came with stent occlusion. So current when the case was written, so he was, despite stenting and repeated debulking, patient was having recurrent hemoptysis, was having dyspnea, had a poor quality of life. So
Right. Right. Dr. Utkarsh, I would like, well, I feel you have given a very important case scenario to us, and I would really want to include one or two opinions on in this case of yours from Dr. Waghray sir that and Dr. Manjunath subsequently, that what should be our step, because practically I think Dr. Utkarsh in his case has done everything which was possible, but there is a failed chemo and the patient is having repeated obstructions. So what should be done now, sir?
This patient, as you have seen, he has almost exhausted all lines of treatment. Chemotherapy, radiation, surgery, post-surgical complications have managed beautifully. But then, as I told you, we have to accept at a time has come that we cannot go on interfering with the patient and go on subjecting him to more financial losses for him, for the family, as well as the social losses. So now we have to focus on his symptomatic treatment, that if he should not be suffering how many more months or years he has life. First, symptom control. If he is hemoptysis, control the hemoptysis. Dyspnea, control the dyspnea. Hypoxia, give oxygen. Fluid effusions there, pneumothorax. You have already done the debulking. If any effusion, put an ICD. So symptomatic management. Secondly, psychosocial support. Because if we see the family, imagine this patient is having all those procedures done, money is spent, and he's still coughing blood and going down in his weight. Obviously, he must be significantly loss of weight and not eating well. So what must be going on in the family's mind? Patient will definitely understand that yes, he is going down. So he needs a lot of confidence and psychosocial support. So symptomatic treatment, psychosocial support, spiritual support at this time plays a very important role. Very important role to give him confidence. We know he's not going to live, but to give him confidence and the dignity of death, what Dr. Manisha has presented earlier. So I think these things now should be the top priority rather than going on continuing with our medical management. I always tell the family, this is what we can do. We'll continue to do. We'll end up in tracheostomy, put him on a ventilator, putting a tube, all those things. But how long he will survive? He will suffer. You will suffer. So if this patient is my family member, I will not do anything. I will go for conservative management only for the symptoms.
Right, sir. Very well told, sir. Dr. Manjunath, I really want your opinion, sir. This is a very important case that Dr. Utkarsh has told, and I am sure आपके पास ऐसे patients for a second or third opinion बहुत आते होंगे कि sir
Yes,
there is
sir.
problem, pulmonologists are doing everything, but अब तो ये surgeon का ही काम है. तो how do you deal with these patients, sir?
Sir, if the patient is having metastatic disease and a central airway obstruction, generally these patients are not suitable for a major thoracic surgery. So unlikely that a surgical role is there. If this same case without a metastatic disease, then definitely there will be a chance for us to give a good palliation as well as plus minus a curative chance for these patients. But if there is already a metastatic disease, then unlikely that surgically we'll be able to do anything. Although I'm sure our pulmonology colleagues are now much more equipped with all the cryoablations and the lasers and all. The kind of bleeding we were seeing earlier, I think that has significantly come down over last 5 years. I think Ravi sir, I think you should be the better person to answer that. And of course, we have a rich panel of people who
Agreed.
knowledge of people.
But my purpose, sir, basically is to understand in this situation how we should look at it. And Dr. Utkarsh, Dr. Manjunath just brought for this point that now pulmonologists are well equipped with some more armamentarium. So what is our armamentarium? What can we do as palliative bronchoscopy?
So for this case, as Dr. Waghray said, I also said the same thing to the patient that if he is my family member, I will stop here. But because the patient was admitted under me and repeatedly family wants to try everything that is possible and they continuously ask you for कि क्या options हैं. So when they ask us कि क्या options हैं, then बीइंग पैलिएटिवली अब हमारे पास ऑप्शंस के अंदर तो ये है कि वी कैन गो फॉर लेजर, वी कैन गो फॉर क्रायो, हम एपीसी, स्टेंटिंग, रीस्टेंटिंग, उस स्टेंट को हटा के दोबारा फिर उसको प्लेस करें। तो बहुत सारे ऑप्शंस हैं जो हैं एज पर थ्योरेटिकली, बट प्रैक्टिकली विद एन ईकॉक ऑफ 3 कैचेक्सिक पेशेंट 38 वेट के साथ में, आई वोंट सजेस्ट दैट वी शुड गो फॉर एनी ऑफ दीज प्रोसीजर्स, क्योंकि उससे क्वालिटी ऑफ लाइफ में कुछ खास इंप्रूवमेंट हम ला नहीं पाएंगे।
नॉट
Yes.
ओनली दैट बट इवन वाइल यू डू द प्रोसीजर, मतलब मंजुनाथ सर, जब आप इन पेशेंट्स को एक्चुअली यू आर डूइंग देम, it is very stressful, and you know at the back of the mind you are always asking yourself why are you doing it actually.
Exactly, sir. This is the point, because it's as simple as that. If a patient cannot undergo a bronchoscopy procedure, how will he tolerate a major thoracic surgery? How will he tolerate a lobectomy or a pneumonectomy? And
Right.
I think that is something which is very valid. Uh, and as Dr. Waghray sir said, these patients should be counseled, and the family should be well educated about this kind of scenario, and offer them more palliative care, and I think close the chapter there. That's one of the
Right,
things.
right. Very well put, but ma'am, I'll just come to you, ma'am. I have our two young Turks, so सौम्यदीप उधर बंगाल वालों को बोल रहा है कि भैया मेरे को क्वेश्चन ही नहीं पूछ रहे। तो अब मेरे को बताओ सौम्यदीप भाई कि डॉक्टर बागरे सर टोल्ड सिम्टम डायरेक्टेड ट्रीटमेंट, सो कैन यू जस्ट थ्रो सम हाईलाइट, हाउ वुड यू लाइक टू मैनेज दिस पेशेंट सिम्टोमेटिकally?
Well, I want to thank Test Council of India for giving me opportunity to share this platform with eminent pulmonologists and oncologists. And thanks to Dr. Ravi sir for kind introduction. So regarding the case, at this stage of ECOG3 with stage 4 malignancy, our intent of therapy will be purely palliative. So the goals of therapy will be to control the symptom, increase quality of life and dignity and care rather than prolonging survival at the cost of suffering. So purely that will be symptom directed care. In case of patient having dyspnea, we may try with low dose oral or subcutaneous morphine, nebulized lignocaine for cough suppression, and giving oxygen if hypoxemic. If patient is suffering from hemoptysis, palliative external beam radiation or cough suppressant and tranexamic acid, if not contraindicated, can be given. And definitely to fight with anxiety component or breathlessness, low dose benzodiazepine can be tried. So that is my take, and purely it will be symptomatic.
Right, right. But apart from symptomatology, Phillips, sir mentioned, or I think initially we had discussed of setting up a multidisciplinary team. So what is your take on multidisciplinary team? Do you set up an MDT in such sort of cases?
Definitely, sir. Now, respected Dr. Waghray sir and Utkarsh, Dr. Utkarsh has already discussed about the options that we have for this patient. Yet, what is better for the patient is not to go for any major endobronchial interventions. Now, this is a pulmonologist's decision. Now, I will need opinions of other experts, like if Dr. Manisha is available, a psychiatrist if is available, and I will discuss with these experts regarding how to plan a further care with this particular patient. First, when I have a discussion with the experts, we will come to a consensus, and this will be explained and counseled to the patient. Now, this patient already knows what he has, so you don't have to hide anything from him. And the next of kin, legal next of kin, he should definitely be there. And the discussion should happen. Ideally, it should be a recorded discussion for medical legal purposes. The discussion should be recorded, minutes of the discussion, and that the patient and the kin understood what we have told them, and they are agreeing to the decisions that we have made together with the family, the patient, and the expert should be consent.
Right, right. Very well told. Now, I do agree with what everybody has told, but I have seen Dr. Manisha wanting to say something from the beginning. बताइए मैम, डॉक्टर मनीषा मैम, ethically हमने बहुत बातें करी. Now, where do we stand?
No, I want to say that first you should ask the patient. Already not just all the treatment, everything is exhausted, but also the patient is exhausted. So first of all, you should ask the patient कि क्या चाहिए उसको, what do you want? Lot of times patient themselves are exhausted and they also understand that it is almost some last days of my life and I just want to be at home. I am just fed up of all these interventions and all. Now I just want to go home. A lot of times they will tell. So first ask the patient, what does he or she want? And the second thing is, there, as sir told, that financial toxicity. If you will tell them that, okay, we don't have much of the treatment options. I have seen a lot of metastatic patients, gallbladder. I have seen. We know that life is so less, but they would have sold all their lands and all, hoping that they will get cured. So we should not overburden them with all those things. So I think other things and all experts have told. So just first ask patient and to the family members, what do they
Okay.
want.
Okay, so I think we have had a comprehensive discussion on basically where we stand as far as central airway tumors are concerned. Now, I would like to move on quickly to our next case scenario, which Dr. Phillips will be presenting. Dr. Phillips, please.
Yes, sir. This is a case that I had a few months back. It was a well evaluated case. It was a 67-year-old female with CA breast, and for some reason, a chest X-ray was taken, and she was referred for opinion regarding a re-emerging pleural effusion. Initially, she had a pleural effusion. Paracentesis was done. Symptomatic improvement was achieved. And now, since the repeat X-ray had an effusion, mild to moderate effusion, in chest X-ray, she came for opinion. Now, this is the case I had. So,
Okay, just I need to, I'll ask this thing that Dr. Phillips, you told that this patient was referred to you. Now, was she symptomatic or asymptomatic?
sir, her vitals were stable. She did not have any respiratory symptoms. It was just an incidental radiographic finding.
That means a asymptomatic pleural effusion with the CA breast came to you basically.
Yes.
Yeah, so that is a really, it is a tough call, and that patient might have been trapped previously, like you told. So I agree with you. Now, this situation nowadays it has been much publicized that there is an ultrasound machine. So, Dr. Utkarsh, tell me how will you use this ultrasound in this particular setting of an advanced malignancy that the patient is having?
The patient is presenting with a malignant effusion, and now the point is to relieve the effusion. So the first thing is number one, एक estimate लगाने के लिए कि क्या है, कितना पानी है, कितना fluid है. Secondly, if we are doing an ultrasound, so septations, loculations and everything वो भी हमें पता चलेगा कि कहीं entrapped lung तो नहीं है. So if we put any of the catheter, ICD वगैरह कुछ भी IPCs करते हैं, पता चले कि नथिंग इज मूविंग ऑन लंग, तो हमारा एंट्रैप्ड ही था. सो वो हम पहले से एक बार ही देख सकते हैं, आइडेंटिफाई कर सकते हैं. थर्डली, एनी टाइम अल्ट्रासाउंड गाइडेड प्लूरल टैपिंग एंड प्रोसीजर्स आर, उनका साइड इफेक्ट्स एंड उनकी कॉम्प्लिकेशन रिस्क जो हमारा कम रहेगा. सो दैट इज ऑल्सो अ बेटर ऑप्शन कि हम इफ वी हैव एन अल्ट्रासाउंड इन आवर फैसिलिटी, सो दैट हैज टू बी यूज्ड.
So the having an ultrasound will be helpful. But Dr. Waghray, sir, I would like to have your opinion, sir. You are practicing over such a vast period previously. This large volume thoracentesis, at times, किसी को effusion है, but please highlight on this large volume thoracentesis, sir, please.
In mostly large volume, this one effusion generally is more than a liter or so. And then so that is when you generally you tap it, but don't remove the entire fluid, and don't do it very fast, because the patient can go into re-expansion pulmonary edema, which you can recognize when the patient complains of some chest discomfort. That's the time to stop the fluid. So don't tap rapidly, and don't tap very aggressively. And then if you have the facility, you can go for a pleural pressure manometry. It will tell you when to stop. But generally, we go by the clinical symptoms. Now, the most common treatment what we give is the intercostal tube drainage. And if it is especially due to any malignancies, then the ICD followed by a pleurodesis. Usually it takes care of the recurrence problem, but sometimes it recurs as well. Again, in spite of the pleurodesis, when you can go and try with a different agent to cause a pleurodesis. If it is still troubling you, the still is a recurrent effusion increasing in amount, then you take the help of either a surgical procedure if a patient is fit enough in the form of a pleurectomy, or you can go for if it is a lung cancer patient and quite sick, then you can go for an indwelling catheter also. So these are the options available with us, but always be careful about the re-expansion pulmonary edema and draw the fluid very slowly.
Right, right. I remember long back, sir, in one of your cases, the patient was symptomatic, and I think at night only I was on duty, and we had tapped out around 1.5 liter. The patient could make it till the next morning, but when I came on night duty that night, but I didn't find the patient again. So I think at least some symptomatic relief that night we could give by this large volume thoracentesis, and that is this taboo कि भैया 1 liter से ज़्यादा मत निकालो. But I think like you told, पूरा मत निकालो. Take it out slowly, and it should definitely not to be the extent to cause rapid expanding pulmonary edema. Now, Dr. Phillips, this your case, you come from the land of interventional pulmonology. So tell me, there is this huge new tool called as IPC. What is this IPC, Baba?
Indwelling pleural catheter, like respected Waghray sir has already talked about. Indwelling pleural catheters are preferred for re-emerging symptomatic pleural effusions, and the process of pleurodesis is also possible through IPC. And the current consensus is to drain the fluid through IPC on a daily basis than as the patient develops symptoms. IPC is much better tolerated as compared to an ICD or a pigtail for long-term usage.
Okay, but is it complication free? डाल दिया और भूल जाओ.
Any invasive procedure is not complication free. There are a couple of complications that can happen after prolonged use of an IPC. The major or the commonest complication is an infection. Infection can happen to the superficial side, the skin, like cellulitis. There could be infection of the tunnel, and there could be an infection of the pleural space also. It can lead to an empyema also. So whenever these complications happen, we have a tendency to think about removing the IPC. But depending upon the complication intensity, for example, if it is a cellulitis, you don't have to think about removing the IPC. You can start them on oral antibiotics that covers basically staph and strep, but also gram-negative pseudomonas, enterobacteria, etc. And then if, or you can go ahead with the local antibiogram if it is available. And if it is not improving, then you can consider thinking about removing the IPC. So tunnel infections are also not that rare, and tunnel infections are usually associated that it can progress to an empyema. Again, if the drainage is positive through the IPC, try not to remove it because it is draining the empyema. The choice of antibiotics will be this time IV antibiotics with anaerobic cover, and if it is not improving, then only think about removing the IPC. And another common complication would be blockade. Blockade of the catheter. You can try flushing with sterile saline, or if there is option of instilling intrapleural fibrinolytics, that can be considered. And one uncommon but not an complication per se or an outcome will be autopleurodesis. When there is an autopleurodesis, now it is the right time to remove the IPC.
Right. So very well said, very well. I highlighted the complications of infection, tube blockage. Dr. Manjunath, sir, often cases might be referred to you. I feel that in what is your take on malignant pleural effusion, sir? Can you help them surgically in some way?
Sir, malignant pleural effusion, I think there are 2-3 indications where surgically we can help. One is when a patient has undergone multiple times aspiration and pigtail and develop empyema, where they start throwing up high-grade fever and become septic, then definitely we need to intervene to do a good clearance and make them aseptic. The other condition is when you have loculated effusion with pleural thickening, and also or there is a pigtail which has caused hemothorax. Sometimes you have interventions done and then there is a hemothorax. Then to evacuate that hemothorax, we might have to intervene. And loculated effusion with pleural thickening, where we see that there is it is not the tumor itself, but the effusion which is causing the collapse of lung. Then we can intervene, and these patients definitely benefit from surgery. Apart from that, I don't think there are other indications. Sometimes we have recurrent malignant effusion where we'll do talc fluoridesis along with IPC for some patients. Those patients should, but the most important criteria for all these patients is the survival should be at least 6 months expected to do any surgical intervention. If you're expecting a survival of more than 6 months, it is worthwhile trying some surgical procedure. Otherwise, no.
Point well taken. Dr. Manisha, ma'am, any ethical advice on pleural effusions, ma'am?
So just follow this four ethical principle. I think all of us should know while dealing with any case. It's not just like a malignant pleural effusion and anything. Even in the previous case also, this autonomy. First ask the patient if the patient is able to take the decision. Otherwise, next, who is the surrogate decision maker? That what they want. Second is the beneficiaries. That you should do always good to the patient. There should not be some interventions which is not at all useful, non-malfeasance. You should not do any harm to the patient. And the fourth one is justice. Justice means you just should do justice to the health resources. What is the hospital resources we have? Justice doesn't mean just justice to patient. It means that just what justice we are doing to the healthcare sector. Like you cannot occupy a ICU bed for a patient who is stage 4, 80 years old, right? And one patient of 13, 14 years old with pneumonia is there outside in your general ward, because you know that you can cure that 14 years old boy if the patient gets ICU support. So especially in our India, where there is a resource constraint setting, you should always do justice to the hospital resources which we have.
Right, right. I fully agree with you, ma'am. And one of our senior physicians from my hometown, Indore, has just put in a very relevant question. Is providing financial assistance to patients, those who can't afford that sort of care, does that also come in palliative care medicine gamut, madam? Is that also an aspect of palliative medicine?
No, like what I think that if our intent is curative, then there are a lot of NGOs and all who are providing support to it. So first, what is the intent of treatment? Whether it is like we have just curative intent completely, or just supportive care, because in that case, the first case which we discussed, right? So even if you will spend crores of rupees, that patient is not going to be all right. So even if you are giving that support, I think that should also be for the curative patient, which I feel that if you think that the patient can recover for it, then definitely we can provide the financial support.
Right, right. So now I'll carry on quickly. We have quite some many case scenarios remaining. So I'd like to invite Dr. Soumyadeep. Soumyadeep, you're here? Soumyadeep?
Hello. Hello.
Dr. Soumyadeep, please, this
Am I
case
audible?
scenario of yours. Yes, you're audible. Please take care of this case scenario of yours, please.
Right. So I had encountered this case 3 months ago. A 62 years old male who is a retired school teacher and smoker 40 pack years, diagnosed with non-small cell carcinoma 6 months ago with stage 4 with bone metastasis. So he presented to our emergency department with progressive facial swelling and puffiness for last 2 weeks, along with distended neck veins, dyspnea that worsens on bending forward, cough with minimal hemoptysis, and severe right-sided dull-lacking chest pain, which disturbed his sleep. On examination, on general examination, he had facial plethora, periorbital edema, dilated neck and chest wall veins. Respiratory system examination revealed decreased breath sound in right suprascapular area, and vitals were stable, and his radiological investigations showed that chest X-ray showing right upper lobe opacity with widened mediastinum, and further CT thorax revealed right upper lobe mass encasing SVC with collateral venous channel visible. Earlier, biopsy was done, which revealed squamous cell carcinoma. So we managed the case symptomatically by giving oxygen supplementation, head and elevation to reduce venous congestion, and IV dexamethasone for reducing edema, and opioid-based analgesic for pain and dyspnea control. Further, we did definitive or palliative interventions, like we called up our radiologist friend, and he did endovascular stenting of SBC, which resulted in rapid relief of dyspnea and swelling, followed by a short course palliative radiotherapy, 5 fraction of 20 Gray given to reduce tumor burden. Palliative chemotherapy considered but withheld due to poor performance status, as he was in ECOG 3.
Right. So I do agree with you. It was quite a comprehensive discussion on SVC, and all of us understand that SVC syndrome is one such case in which palliative care is of utmost importance. It is very difficult to actually go ahead and offer some curative treatment to that patient. Although getting a proper CT venogram with proper cuts helps us in diagnosing of that SVC obstruction. So now I would like to quickly move on to one more common case scenario which we commonly see, and I would like the opinion of our panelists in that. A 58-year-old male who was a chronic BD smoker presented to the ER with multiple bouts of hemoptysis with every cough, and it was fresh red in color. He had recently undergone a diagnostic bronchoscopy with the biopsy report awaited. He had no fever, trauma, or use of anticoagulation. He had been restarted ATT empirically as he developed weakness and non-responding cough over the past 6 months, and history of old TB 21 years ago. On examination, you find that the patient is conscious but quite pale. His BP is 90/60. He's having tachycardia, tachypnea, and there is grossly decreased breath sound in the right infrascapular area. You call up the pathology lab and you're given the report that tentatively the bronchoscopy biopsy looks to be something malignant. Now, sir, Pradyut Waghray sir, in this patient who has massive hemoptysis with a suspected bronchoscopic biopsy of malignancy, sir, how would you initially evaluate this patient that he comes to you, sir?
The most important thing in a case of massive hemoptysis to secure a safe airway first, so that we prevent him from going into aspiration. So first, secure airway. And then, if you are having facility for a bronchoscopy with a cold saline or a balloon, then you try to block it and stop the bleeding. And try to get a CT pulmonary angio as early as you can. Before you do that, always see that the stabilization of the patient is met. As you mentioned here, BP was 90/60. He was tachypneic and hypotensive. So obtaining an airway, stabilization, what we call as ABC. Then, if you have a facility, try to control the bleeding and arrange for a CT pulmonary angiogram or a bronchography for a subsequent bronchial artery embolization to stop the bleeding. That's the first thing, to control the bleeding. Now, once you have controlled the bleeding, if it is not controlled by embolization, then it becomes a surgical candidate. Most of the times we are able to do it with after the balloons, everything, we are able to stop the bleeding also. By that time, your biopsy report will come. And if it shows any malignancy, then the subsequent treatment can be started. Massive hemoptysis, secure airway, stabilize the patient, try and control the bleeding, whatever means you have, eye saline, balloon, or just giving a pressure with your rigid bronchoscope, and then arranging for a bronchial artery embolization.
Right, sir. I think not only the initial evaluation, you have also discussed the diagnostic workup and even the management of massive hemoptysis, sir. But tell me, Utkarsh, minor hemoptysis, sometimes, you often get patients from a call from your patients from home, that patient is having some streaky hemoptysis. So can you share some tips on managing minor hemoptysis?
So for patients like a patient who is a follow-up case, so definitely I would like to first, if it is a follow-up case, obviously there would have been some kind of a diagnosis that would be there, something presumptive or something, old history of tuberculosis or known case of a malignancy, or the patient would be on ecosprin or antiplatelet drugs. So any of these kind of history that would I would like to take firstly. After that, if the patient has, I would suggest to go for a chest X-ray if nothing has been done, and this is the first time that the patient is coming up with the minor hemoptysis. Though patient has a minor hemoptysis today, doesn't mean that for tomorrow this couldn't increase or something. So any kind amount of hemoptysis is ought to be taken care of. I would suggest patient to take antifibrinolytics, tranexamic acid, and something. And along with that, if there is enough of cough, so uh, cough syrup would be better. So I
Suppressant, cough
prefer
suppressants might be
cough
useful.
suppressants.
Right, quite right. Dr. Soumyadeep, would you have anything extra to add to the management of massive hemoptysis?
The esteemed panel already have mentioned that immediate stabilization, that is ABC, airway, breathing and circulation management, positioning, that is bleeding side down, correct the coagulopathy, localize the bleeding site by imaging, chest X-ray, urgent CT or CT angiography, followed by rigid bronchoscopy preferably, and suctioning and removal of the clot, and the definitive intervention like bronchial artery embolization. There is a first line intervention radiology technique, followed by palliative radiotherapy and surgery, rarely, but only for localized disease with good functional result, preferably lobectomy or pneumonectomy.
Right, right. Waghray sir, you wanted to make a point, sir,
Yeah,
please.
this for this small, small strips of blood in the sputum, there is a condition called sentinel bleeding, which is actually precurs a massive hemoptysis. So if your patient of lung cancer is having this repeated small bleeding, just be prepared that this fellow may come to you with a catastrophic massive bleeding. That's one thing. And one other important practical thing, if you're able to locate the site of the bleeding, ask the patient to lie down on the side of the bleeding so that he doesn't go and aspirate the other side. Just one practical point.
Right, very important and very relevant point, sir. Now, coming to my dear Dr. Phillips. Phillips, tell me, do you know of any neurological emergencies which we may see in lung malignancies? Any neurological issues?
Yes, sir. For example, most common neurological emergencies in lung CA is secondary to brain metastasis. So the patient may present to you with headache, nausea, and altered sensorium. And this is usually secondary to raised intracranial pressure. Seizure is also a possibility, focal neuronal deficits. And the second most common is spinal cord compression, which is second most common of MSCC. And the emergency is irreversible paralysis if not intervened fast. Third one being leptomeningeal carcinomatosis, and emergency is rapid deterioration due to widespread CSF seeding. And then there are other paraneoplastic neurological syndromes. And then there are metabolic also related emergencies, hyponatremia due to SIDH and hypercalcemia of malignancy. There could be cerebrovascular events also, which is due to hypercoagulability, which can lead to stroke, etc.
Right, right. So now I do understand that there are several other aspects like cardiac emergencies, which our patients face apart from neurological. So, Dr. Utkarsh, any cardiac emergencies that we might face in lung cancer patients?
Yes, sir, because lung cancer will metastasize, and if there is any kind of pericardial effusion, so it could lead to pericardial tamponade and cardiac tamponade. Other than that, there are arrhythmias, commonly supraventricular tachycardias, which are very common with carcinoids and pheochromocytomas. Then we could encounter the compression of the major vessel because of the tumor, causing obstruction, coronary obstruction, and that could eventually lead to an immediate cardiopulmonary arrest. Other than that, there are few like treatment-related complications of the cardiac, so we'll discuss that later. I think DVT, embolism, and everything.
Yeah, we will discuss embolism later.
Yeah.
Now, I would like to move on to one very important thing is, which is another case scenario, sir. A 78-year-old female presents to a 78-year female, thin built, chronic tobacco chewer. They present to you for follow-up with complaints of progressively worsening dyspnea. The family complains about her inability to walk to the toilet or even walk to the door to do basic errands. The family is concerned as rainy season when she often falls sick is coming. She is on regular treatment for lung cancer under a medical oncologist. On examination, you find that the respiratory rate is 28, saturation is 94%, but accessory muscle use is there and bilateral rhonchi are present. So this presentation of dyspnea in a lung cancer patient was seen in this patient. So Dr. Soumyadeep, I would like to ask you, what are common causes of lung cancer or of dyspnea in lung cancer patients?
Causes like tumor-related causes, treatment-related causes, or general causes. So regarding tumor-related causes, maybe endobronchial or extensive compression of the tumor of the airway by the tumor, or maybe massive pleural effusion or pericardial effusion, or maybe superior vena cava obstruction that may lead to sudden shortness of breath. Treatment-related causes, that means radiation pneumonitis or fibrosis or chemical pneumonitis, or surgery related to loss of lung tissues. And in general causes, anemia, pulmonary embolism, these are the major causes of dyspnea in lung cancer.
Okay, Dr. Phillips, are there any contributing mechanisms separately in malignancy cases for dyspnea?
There are a few mechanisms, sir. When there is increased pulmonary artery pressure, there is increased airway and lung pressure also, and these will stimulate the baroreceptors, the irritant receptors, the GR receptors, and mechanoreceptor receptors, and this will contribute to dyspnea. And such receptor activation can also lead to increased respiratory muscle use and activate chest wall receptors, again, that is contributing to dyspnea. And for this particular patient, we'll definitely have an possibility of increased reduced PCO2 and increase in PaCO2, and this will activate the chemoreceptors, again, that will contribute to dyspnea. And patient will have a what we call reduced airflow, and there will be a perception of dyspnea as such. And the other psychological point of view, there will be an emotional distress, etc. And patient will be disturbed in such points also.
Right. So, but then there are two ways to look at it. One is as a pulmonologist managing dyspnea, and another is as a palliative care medicine specialist managing dyspnea. So tell me, Dr. Utkarsh, how would you manage or approach this patient of dyspnea?
So firstly, a patient presenting with dyspnea will look for the saturation. If the saturation is below 90, then first thing would be supplemental oxygen, and also the respiratory rate. If it is going too high, patient is tachypneic. So I would also like to give NIV or BiPAP supports. Apart from that, if these things are okay, but the perception of dyspnea is too much, then opioids, slight morphine could relieve the pain and could help in the perception of breathlessness. Apart from that, for the long-term management, I would suggest to do some kind of breathing exercises going towards pulmonary rehabilitation that would help patient in feeling better in relieving that dyspnea. Sometimes in case of radiation pneumonitis, I think steroids are also indicated. So if it is indicated in certain cases like central airway obstruction or something, that could also help in relieving dyspnea.
So, Dr. Manisha, like Dr. Utkarsh told about some ways of managing it pulmonology wise, as a palliative care specialist, how would you approach to dyspnea in such a case?
So I would divide it like BTF, breathing, thinking, and functioning. Like the patient will have an increased work of breathing and all. So what we will have to do, we will have to decrease the work of breathing. And we all know that there are some receptors on the medulla. So by giving the opioids, this will decrease the sensation of their breathing. So opioid is useful in that cases. Apart from them, just thinking. Thinking means the patient will have that sensation that they will have fear that I will have that feeling that I am having that dyspnea. So what we can do in this thing, we can give, and the patient will be so much anxious. So we can give in a low dose of benzodiazepines like lorazepam 0.5 milligram or midazolam in low doses can be given just to decrease the anxiety. And sometimes this CBT can be offered to the patients. And I think drugs and all, steroids and all already has been discussed by the previous speakers. Apart from then that functioning, so we can provide some aid to the patient, like the patient is going to washroom and all, like going without any support, they can use some aid. And physiotherapy like pulse sleep breathing, that can be very beneficial for these patients. And if opioid is concerned, usually what I use two opioids which I am using. One is the morphine, which usually I give in 5 milligram every. You can give in QID to 4 to 6 times a day can be given for breathing difficulty. And another, apart from that, fentanyl can also be given in the dose of 50 microgram every 3 to 4 hourly. You can give.
Okay. So, Waghray sir, lot of drugs have been mentioned, sir. Please, sir.
Yeah,
Some
whatever the basic rule is in a lung cancer and dyspnea, number one, try and find out what is the cause of dyspnea and is it treatable or not. In this case, she's having V's. Maybe you can try nebulizers. We can go for NIV if she's having any CO2 retention because a smoker earlier. Then, if the cause could be due to a fluid effusion where you can tap and remove the fluid. One important thing we always miss in malignancy is venous thromboembolism. Anybody complaining of blood, always look out for venous thromboembolism and try to rule it out. And if then nothing is, if you don't have a treatable cause, your patient is terminally ill, then you have the opiates are the best drugs to make him comfortable. And of course, as madam has said, benzodiazepines to relieve anxiety and other issues. But treatable cause first, oxygen, NIV. If nothing is there, no cause is found, then opiates.
Great. So, Dr. Manisha, ma'am, I think opioids for dyspnea, you must be using very extensively. Just could you give a short overview as to the use of opioids, how we can use them effectively and safely?
So, like in dyspnea or like in everything?
You can go ahead, like
Yeah.
with the indications we will be discussing on cough also subsequently. If you, I would just like you to enlighten us on how to use opioids properly.
Yeah. So there are a lot of indications for using the opioids. First, obviously, for everyone which is using widely is for the pain management, right? And also we can divide it like it is weak opioids or strong opioids depending on the intensity of pain. Second one, of course, if the patient will be terminally ill, there will be terminal breathlessness. In that, we can use other thing which we can use is for the cough. It is an excellent cough suppressant. After that, we can use even in the terminal, even the sedation, when we are giving the palliative sedation to the patients. In that case, also, we can give it with midazolam or any benzodiazepine which we are giving to the patients. So it is having a multiple use. And even at few places, like in Nepal, which I know, they have the syrup of morphine. So if the patient will be having mucositis, so that can be applied locally as well. But unfortunately, in India, we don't have. So these are the multiple uses of opioids.
Right, ma'am. Very, very well highlighted, ma'am. That because using opioids always we tend to be a little bit on the back foot. So we have to be a little bit more careful and more open to using them in this particular
And
setting. Now, yeah, please,
and just
please.
start just with the lowest possible dose, and slowly by assessing the patient, we can increase it slowly. So just
Okay.
start slowly and you can increase it slowly.
Right. Now we have one more case scenario. Dr. Phillips, I would like you to help me in this case scenario. A 48-year-old male recently started on chemotherapy for his cancer, diagnosed around 3 months ago. He was a social smoker when a mass was picked up on health checkup and the biopsy revealed malignancy. Of late, since the treatment has been initiated, he developed with scanty expectoration, chest pain, and streaky hemoptysis. All of his cultures came to be sterile. He developed the same after his chemotherapy cycle, but responded after a 1 month antibiotic course. So, can you please tell us, Dr. Phillips, that what could be this happening in this case of lung malignancy?
Right, sir. Now, there are multiple possibilities when an already diagnosed case has a pneumonitis. It could be a pneumonia. It could be a treatment-related pneumonitis. There are multiple possibilities. So when there is a new respiratory symptom in an already diagnosed case, I would go for an HRCT thorax. And if the CT thorax is consistent with the previous CTs that are available, we'll continue therapy without any disruptions. Now, if there are new lesions in the CT thorax, I'll probably try to exclude other disorders like TB, pneumonia, fungal infections, any viral pneumonias, ILDs, pulmonary embolisms, etc. And I will also try to gain a further microbiological and probably, if required, bronchoscopical evidence for the new lesion. And if there is a suspicion of a differential disorder with evidence, I would have an MDT discussion with the other experts that are in the field regarding continuation of the treatment or delaying the treatment. And if there is still there is a strong suspicion of treatment-related immunosuppression pneumonitis, and I will probably discuss with my oncologist regarding delaying the treatment, depending upon the grade of the pneumonitis that is there. So if it is a mild pneumonitis, I'll probably delay the immunotherapy, monitor symptoms, and repeat an X-ray after 2 or 4 weeks, see if it is resolving or increasing, and then plan forward. If there is it's a moderate pneumonitis, for example, moderate involvement in the CT thorax, I'll probably delay immunotherapy, monitor symptoms closely. I'll definitely consider hospitalization, and I will re-image with chest X-ray every 2 to 3 days. Infectious diseases are already ruled out, and I would probably put him on methylprednisolone so that the pneumonitis resolves faster. And if it is severe, I will definitely stop immunotherapy for the time being. Again, methylprednisolone will be my drug of choice. And if there is no improvement in the first 48 to 74 hours, I'll probably consider immunosuppressants like mofetil or infliximab.
Okay, so what basically we need to understand is patients of advanced lung malignancy, if they develop clinical features of pneumonitis, it can also be a non-infective pneumonitis in which we actually need to treat it with steroids rather than antibiotics because they are all microbiologically negative. So now I know it's getting very late, but there are 1 or 2 very important case scenarios which I think we need to discuss, which I'll try to finish up very quickly. Now, I would like to share another important case scenario of a 69-year-old female presenting to you after returning from her 5th cycle of immunotherapy for lung cancer, which was diagnosed 6 months ago. She complains of dry hacking cough, severe, which poorly responds to inhalers and anti-allergics she used before her diagnosis. She is concerned as while coughing, she often feels distress, shortness of breath, and point tenderness in the right infraaxillary area. She is also taking some indigenous medicine for her cough, which they say works well for 10 minutes, after which she starts coughing again. So I would immediately like to pass the baton to Dr. Pradyut Waghray sir. Sir, what are the common causes of cough which we see in lung cancer patients?
The cough in lung cancer could be due to the tumor itself or could be due to the treatment they receive. The tumor can cause simple irritation inside the tracheal, the bronchial lumen, or it could cause obstruction and cause the cough. It could be due to other complications of the disease like pleural effusion, for example. Regarding the treatment part of it, it could be due to the radiation. If the patient has received radiation-induced pneumonitis, radiation-induced fibrosis, they can cause dry cough. It could be due to a spread of the disease, what is carcinomatous lymphangitis, present with dry cough and breathlessness. And in this case, since he has taken immunotherapy itself is known to cause inflammation in the lung and induce cough. So these are the common, and of course, we always have to think, because these patients are on immunosuppressants, they are always common to develop infections. Infections could be due to post obstructive pneumonitis or due to the immunosuppression caused by the drugs. They could result in various type of typical and atypical infections which can present to us as cough. So these are all the things you have to keep in mind in a case of lung cancer.
Right. So, very well explained, sir. Dr. Soumyadeep, what are the common medicines that you tend to prescribe for cough in palliative care?
So the first line of distressing cough in palliative care is opioids. So low dose morphine may be 2.5 to 5 mg orally 6 hourly, or maybe in syrup codeine or hydrocodone. Alternatively, if morphine is not tolerated, they actually act centrally to suppress cough and cough reflex. So start low and titrate the dose, monitor for constipation and drowsiness in case of opioid. And in opioid intolerant patient, non-opioid antitussive like dextromethorphan or benzonatate, that is peripherally acting, reduces cough reflex sensitivity, can be used. In based on causes, if we use adjuvant therapies like corticosteroid, usefully if cough is due to airway inflammation or due to radiation pneumonitis. Bronchodilators if coexistent bronchospasm, or antihistaminics or PPI if GERD-related cough. And refractory cases, as last resort, pregabalin or gabapentin for neuropathic cough component, and sedation midazolam only in end-of-life refractory cough with severe distress. And recently, a paper was published regarding refractory cough in small cell carcinoma. They used gefapixant, that is recently FDA approved P2X3 antagonist. There is a wonderful drug, and that can be used in case of this refractory or last resort cough.
Right. So, definitely there is a whole gamut of drugs which are available. If I would have more time, I would have even asked Dr. Manisha which are the drugs which don't work but still people use. But we are really falling short of time. So, I would like to now go to Dr. Soumyadeep, who I think has a very important case scenario to discuss with us. Dr. Soumyadeep, please carry on with your case. Dr. Soumyadeep?
So actually, yes.
Yeah.
58 years old male, diagnosed with stage 4 adenocarcinoma, ECOG3 of right lung, and with bone and liver metastasis. So he presented with severe right-sided chest pain relating to shoulder and back. VAS score was 9 out of 10, and the pain aggravated by coughing and movement, poorly controlled with current medications. So he was treated with NSAIDs, that is as WHO analgesic ladder. Step 1, NSAID were given. Step 2, tramadol and paracetamol were also given. And at step 3, oral morphine up to 120 mg per day was also given. But after giving highest dose of morphine, the pain is intolerant. So we have tried. So next slide, please. So despite optimization, patient had refractory pain, and CT thorax revealed that progression of primary tumor with rib metastasis and liver lesions. So what we did, we optimized the opioid, rotated from oral morphine to transdermal fentanyl patches, and added rescue morphine. There is the 10% of the initial morphine dose. Adding with that, adjuvant analgesic, gabapentin, and bisphosphonate, as the patient is having rib metastasis, and dexamethasone to reduce the anti-inflammatory and to reduce the inflammation and edema. Along with that, interventional palliative procedures like intercostal nerve blockage was used, and intrathecal morphine infusion. So after that, after giving all these things, within 1 week of opioid rotation intercostal nerve block, the patient came to us, our OPD, with improved VAS score. That is from 9 out of 10 to 4 out of 10, and sleep quality was also improved. Patient could ambulate short distance, and the patient was continued on transdermal fentanyl patches with adjuvant, follow up by home-based palliative care lesions.
Thank you. It was very well managed. But Dr. Phillips, tell me, what are the common causes of pain in lung cancer patients?
So when we think about pain in lung cancer patients, first we'll think about pain that is due to chest wall and parietal pleural invasion. Peripheral lung tumors that invade the pleura, ribs, muscles, etc. And the treatment of choice will be analgesics, palliative RT, and nerve blocks in such pain. Then second, we'll think about pain due to bone metastasis, especially in case of osteolytic lesions due to periosteal stretch, inflammation, or nerve sensitization. Again, treatment of choice here would be opioids, bisophosphonates, RT, and surgery if indicated. And neuropathic pain from nerve invasion also is a possible cause in lung cancers. For example, in Pancoast tumors, if intercostal nerves are involved, and in radiculopathies. And here we'll think about opioids, gabapentinoids, RT, and nerve blocks again. And from my favorite, malignant pleural effusions in case of pleural nodules, and pleuritic pain is very common. And then we have already discussed regarding thoracentesis, IPC, pleurodesis, etc. Pain can also be caused due to visceral metastasis if there is capsular stretching. For example, hepatic or adrenal capsular stretch. It can be due to pathological fractures. If there is a pericardial disease, that can cause pain. And some of the times, the pains are mixed. It can be neuropathic, and it can be visceral organ-related pain also. So we will need an expert in pain management to actually decide on how to deal with this pain.
Right. So, Utkarsh, can any of the treatments also cause pain in these patients?
Yes, sir. Firstly, before treatment, biopsies would cause pain. Then, surgical pain, post-surgical pain is also a major cause. It's a long-term pain that is because of the surgery. Radiation-induced pain is also a known factor. And then some chemos, bisphosphonate drugs, they cause peripheral neuropathies. So these kind of pain are also very common in patients with chronically managed with pain. Yeah.
Right. Dr. Soumyadeep, you very elaborately managed your patient and told us many things. Anything else you would like to add about the role of opioids in pain management?
So actually, there is a term called opioid rotation. If one opioid is ineffective at maximum dose, so we can rotate the opioid. Suppose if the patient is one opioid, then we can switch to fentanyl itself, morphine to fentanyl or fentanyl to morphine, and we can add rescue opioid dose. That is when the pain was controlled to the optimum dose of opioid, 10% of the optimum dose of opioid that can be used as a rescue dose.
Right, right. So, Dr. Manisha, I would like to understand two concepts of pain management. What is breakthrough pain, ma'am?
So it is just a transient exacerbation of pain. So first thing, when everyone told that you should give this drugs or things, first of all, one thing you should tell patient that you will have sometimes that in between, that incidental pain. So breakthrough pains are usually of three types. First is that incidental pain. So the patient, if is having that vertebral mets, you will have to tell patient that, yeah, there will be 20 to 30% of exacerbation of pain when the patient will try to walk, because the patient will have expectation that he will have 100% of pain relief. So this is called Kalman's gap, that we should explain to the patient, that patient's expectation will be of 100% pain, but the real, what is the real, we are just trying to control around 75 to 80% of pain. So this we need to explain to patient. Second thing is, like, sometimes they may have some pain due to some muscle spasm and all. And the third thing is their end of dose pain. So usually what happens, we will give morphine every fourth hourly, but maximum, most of the times, the cause of pain, even if after everything, is just because of the end of dose pain, because patients will take either 2 or 3 times a day. So we should explain patient that what is the need of taking any drug or any analgesics at a particular interval, and also a few times these incidental pain are normal. And what I usually tell that, like, if I have to give morphine fourth hourly, so the one dose will be around 6 or 6:30. What I usually tell patients, okay, if you are getting at 6 or 6:30, you just first take the morphine. Its action will take around 30 to 40 minutes. Then you go for that activity. So at least during that activity, his or her pain will be decreased. So this is my way.
Right. Dr. CVK sir has just added us a reminder to talk about two very other important drugs like antidepressants, duloxetine, and even tapentadol is there. Any comment on that by the panel?
Yeah, so just for duloxetine, I would tell that it is SNRI. So the one indication which is usually we do here is the chemotherapy-induced neuropathy. It is the only drug which has been approved and is having the moderate recommendation for chemotherapy-induced neuropathy. So for that, usually just you can start with 20 milligram HS doses, and slowly we can increase it. And the second one is tapentadol. It is usually used for the moderate to severe pain.
Right, right. Now, some other very common complications which we see mostly in cancer-related patients is cancer-related nausea and vomiting and even diarrhea. So tell me, Dr. Utkarsh, cancer-induced nausea and vomiting, what are the types of these things that we see commonly?
Commonly, sir, which can be classified like into uh, acute, delayed, refractory, anticipatory MSS. So this is chemo-induced nausea and vomiting. So acute, we as every time it's less than 24 hours. Delayed goes from 1 day to certain weeks to around 2 weeks of time. Then there is an anticipatory, that is a conditional response that patient has known from the previous experiences of the chemotherapy. There is a type that is refractory. So refractory, we say, is even despite that we have given a prophylactic antiemetic, and then also there is nausea and vomiting that is occurring. And there is a fifth type also, that is a breakthrough nausea vomiting. So that is what we say within 24 hours to 5 days of time period. So there are basically 5 types of chemo-induced nausea and vomiting. So
Right.
which
Right. Dr. Phillips, what are the common agents that are used for this cancer-induced nausea and vomiting?
Right, like Dr. Utkarsh has very beautifully classified the types of CINV. The commonly used antiemetics are our ondansetron and that group of drugs that is effective mostly in delayed CINVs. Another group of drugs is NK1 receptor agonists, where delayed CINVs, they are very helpful in delayed CINVs. And the major drug that can help is aprepitant and fosaprepitant, neutropitant, etc. We can also consider giving corticosteroids, for example, dexamethasone, which is most extensively studied for rescue therapy in breakthrough CINVs. We can also consider dopamine agents like haloperidol, then this is definitely for breakthrough therapy for CINVs. And there are limitations when you use dopamine agents for example, extrapyramidal symptom risk, but it is less effective than our commonly used antiemetics like ondansetron. Uh, Olanzapine can also be considered, be it being an atypical antipsychotic. Benzodiazepines can be considered, for example, lorazepam. Even though it has no antiemetic properties per se, it can be useful in anticipatory CINVs and anxiety-related nausea. Theoretically speaking, cannabinoids can also be considered.
Excellent. A whole gamut of drugs are available which we very uncommonly use, but they are there. So it is not the usual drugs that we should stop on. We should think of giving combination of drugs in this particular subset of nausea and vomiting. Now, due to the paucity of time, I have had to cut down on several aspects. But there is one aspect which I need. I would request 5 minutes from all of your precious time is that of cachexia. Well, Manisha ma'am, please tell us cancer-induced cachexia is one thing which we see in all our patients. And I would like to understand from you how you go ahead and manage these cases of cachexia in these end-of-life care patients, please.
So cachexia will define as pre-cachexia, cachexia, and there will be like completely you cannot change it. Then what happens usually the patients which mostly do come to us is like high grade of cachexia. There will be muscle loss, and we will have to first explain to patient that it is actually difficult to treat the cachexia. But what we can do if the patient is like end of life and you have just few months of life, first of all you should look for that if there is only what is the cause why the patient is not eating, whether there is any mucositis or if there is some obstruction, it is continuous vomiting. So first you should treat the cause. Sometimes that due to some deficiency like zinc and all, the patient will be having loss of taste. So first of all, what you can treat is that should be taken care of. Apart from that, there are also some drugs like migestrol acetate, which we are commonly using. Apart from them, dexamethasone that can be used. And one more thing, that olanzapine, yes, it is an antipsychotic drugs that can be used, which will actually increase the weight of the patient. And a lot of times it happens that patient is having a lot of distress just because that he is looking thin, he or she, and he is not able to fit in his older clothes. So a lot of you should counsel the patient, it is okay that you are not fitting in that, even that then also you are just looking awesome. And regarding the nutritional supplement, it's better to ask patient whatever they want they should eat. In case if they want specific some nutritionist or something like that, otherwise I always advise patients that whatever you want, you just have it. That will give you more happiness rather than going through like high protein, low protein diet or whatever. Like if it is like it is irreversible cachexia, but initially we should have we should prevent the cachexia by having a proper diet. And but palliative care, it's like migestrol, which I'm usually giving.
Right, right. Very, very nicely answered, ma'am. And it is very important because that you told that cachexia is one such thing which you can automatically identify in your patients, and it makes you feel very odd as to where your patient is headed to. So I would like to deeply apologize for keeping all of you till 10 p.m. Usually we wind up by 9:30. That is why I even had to look over a few important topics which were to be discussed, like hematological disorders and some other conditions like tracheoesophageal fistula. But I feel we need to be punctual. We are actually quite late. So I would just like to thank all my panelists and request a particular take-home message from all my fellow panelists. I would like to begin by a take-home message from Dr. Soumyadeep Ghosh from Burdwan, Bengal.
Thank you for giving me such an opportunity in CCI platform. So actually, my take-home message in palliative care medicine is actually we have to we have to make the patient family member understand that the patient is actually going to die, or nothing can be done in case of stage 4 and stage. So that should be accepted by the patient party as well. And the communication skill we must develop uh, to counter this kind of situation in stage lung cancer patients.
Okay. Thank you. Thank you, Soumyadeep. You have been wonderful. Now, Dr. Utkarsh, your take-home message for today's webinar's listeners.
Sir, I'll say that we should give preference to the patient and the family beliefs, taking care of their cultural, their social, that the holistic care approach from the relief of the symptoms to the social and the cultural beliefs of the family, talking about everything in detail with the patient and the family so that his dignity is maintained and he can go for a peaceful death.
Right, right. Very well summarized. Dr. Phillips, what is your
Yes.
take-home message for our 1,131 audience who has logged in to look to have a listen to what Dr. Phillips is going to say on palliative care medicine?
First of all, thank you, CCI Ravi Dosi sir, and everybody is still with us. More than 1,000 logins. First take-home message that I would think about is importance of palliation early on. Two, irrespective of the tools that we have, should we use it? Why we should not use it? Three, importance of MDT. Four, the psychological and religious beliefs of the patient regarding his terminal illness. Thank you.
Right, right. Very well said. And I really appreciated your entire participation, Phillips. Excellent speaker. I wish you the very best. Now, I would like to call upon Dr. Manisha, ma'am. You, as our palliative care medicine specialist, this was your webinar, ma'am. Please, a take-home message for all us pulmonologists.
First of all, I would like to thank CCI for this opportunity because it doesn't usually happen that someone from palliative care will be given this much of opportunity. So, thank you for this opportunity, and I think I learned from such senior pulmonologists, and it is like great opportunity to listen to all of you. I think I can decide, like, also I have got some picture, like for what cases I should refer to a pulmonologist. Like, lot of times there are dilemma, and as I'm mostly working in a cancer setup, so sometimes seeing that I got a better picture that when actually I should refer to a pulmonologist. So thank you so much.
Thank you, Dr. Manisha, ma'am. It was wonderful to have you on this wonderful academic platform of CCI. And I would like comments from our respected teacher, Professor Dr. Pradyut Waghray, sir. Thank you for sparing time. Sorry for making you late, but sir, please, some words of wisdom for us to take home.
It was a pleasure to be with all of you. Thank you so much, Ravi and Atri, when they sent the message to me. And Manisha, madam, thank you so much, and all the other panelists and CCI. From my 40 years of journey in medical practice, what I have realized is in our younger days, we are very eager, ventilator, aggressive treatment in a dying patient also. But then as you go along, you realize that there should be a definite dignity in death. So please don't treat the patient as an isolated organ. I am a lung specialist, you are a heart specialist, you are a brain specialist. Please treat the patient as a whole. And what we read in the SPM, medical, social, and mental well-being. So all this thing is important. Treat the patient as a whole, holistic management, and please make use of the palliative care. Don't think it's the end of life care. It's totally different. Thank you so much. I think I have conveyed the message.
Thank you. So to sum it all up, I have been full of Rajesh Khanna dialogues. So I would like to end one with a Rajesh Khanna dialogue कि बाबू मोशाय जिंदगी और मौत ऊपर वाले के हाथ में है जहां पना वो जब जैसा चाहे किसी की भी वो खींच सकता है बट the thing is we as doctors have the power to at least make that life worth living by giving proper palliative care and with an empathetic message. वो भी अपना भाई है, उसकी फैमिली को भी उसकी चिंता है. We need to take care of this चिंता aspect and try to come down on the stress of these patients in every way possible. So a big thank you from the house of CCI to all of you, to the listeners, panelists and audience. Thank you very much. Good night.
Thank you so much. Bye.
Thank